Hello and welcome back to part 2 of the fundamentals of advanced pharmacology. My name is Lorraine Hu and I will be doing this PowerPoint presentation. In part 1 we discussed the passage of drugs across membrane barriers. The passage of drug molecules across a cell membrane depends on the physiochemical nature of both the drugs and the cell membrane. Cell membranes are composed of protein and a bilayer of phospholipid, which act as a lipid barrier to drug uptake. Thus, lipid-soluble drugs generally diffuse across the cell membranes more easily than highly polar or water-soluble drugs. We learned that small drug molecules generally diffuse more rapidly across cell membranes than large drug molecules. If the drug is bound to a plasma protein such as albumin, the drug protein complex becomes too large for easy diffusion across the cell or even capillary membranes. We discussed drug transport to and from target cells by simple diffusion, facilitated diffusion, and active transport. This is a diagram of modes of drug transport. Passive diffusion does not require energy. Most drug absorption from the GI tract occurs by passive diffusion. Absorption is favored when the drug is in the unionized or non-ionized form or more lipophilic form. Drugs that have a low pH or drugs that are more acidic are better absorbed from the stomach, where the pH of the stomach is somewhere between 1 to 2. Facilitated diffusion requires specific transport mechanisms, but no energy is required for this process. However, active transport requires energy. Sodium potassium ATPase is an important example of active transport mechanism that is a therapeutic target of Digoxin in the treatment of heart failure. In part 2 of this presentation, we're going to focus more on pharmacokinetics. Pharmacokinetics is what the body does to the drug or the action of the body on the drug. It specifically involves the processes of absorption, distribution, metabolism, and excretion. You often see metabolism and excretion grouped together as drug elimination or drug clearance. The overall processes depend on drug levels in the body, the onset of action, the peak effect of the drug, and duration of action of the drug, the therapeutic effects and adverse effects of the drug. Understanding the principles of pharmacokinetics increase the probability of therapeutic success and reduce the occurrence of adverse drug reaction, also called side effects or adverse events. Absorption is the time a drug enters the body to the time it enters the bloodstream. Well, in this case, it depends on how a drug is administered. If given intravenously, the drug is virtually 100% bioavailable, whereas if the drug is administered by mouth, it is less than 100% bioavailable. Bioavailability describes the fraction of the administered drug dose that reaches the site of action or in the systemic circulation from which the drug has access to its site of action. Bioavailability is basically the percentage of administered dose that reaches the systemic circulation. Oral formulations may vary with the process of absorption. If the drug was liquid, it does not need to be dissolved first. When swallowed, it is rapidly moved through the stomach and small intestine and our small intestine has a large surface area for absorption of nutrients and drugs, and then the drug is transported into the portal circulation from there, or the portal vein. Liquid medication is more rapidly absorbed than tablets or capsules. However, the presence of food in the stomach may slow the rate of absorption for many drugs and may decrease the amount of drug absorbed. The absorbed drug passes through the liver, where the metabolism and biliary extraction may occur before the drug enters the systemic circulation. So the important concept here is that the drug moves from the stomach or the small intestine to the portal vein or the portal circulation and goes into the liver, where it is metabolized, and then it is transported into the systemic circulation. And the systemic circulation is where the drugs are taken to the site of action. Okay, so there's a difference. Prior to the liver is portal circulation. After the liver is systemic circulation. So this is a very important concept to remember. So the important concept is to understand that less than all the administered doses may reach the systemic circulation and be distributed to the drug's sites of action. If the metabolic or the excretory capacity of the liver and the intestine for the drug is large, bioavailability will be reduced substantially. But this is the first pass effect. When drugs are given orally, they are absorbed from the GI tract and carried to the liver through the portal circulation. Some drugs are extensively metabolized in the liver, with only part of a drug dose reaching the systemic circulation for distribution to the sites of action. This is called the first pass effect. Subcutaneous or intramuscular drugs are usually absorbed faster than oral drugs as they move directly from the injection site to the bloodstream, especially intramuscular sites, as muscle tissues have an abundant blood supply. Systemic absorption can occur from mucous membranes, from mucosa of the oral cavity, nose, eye, vagina, and rectum. Our lungs have a large surface area for absorption. There are few drugs and inhaled anesthetics that work here. Distribution is the transport of drug molecules within the body. Distribution of drugs depends on the adequacy of blood circulation. Heart, liver, and kidneys receive the most blood supply. Accumulation of drug into tissue is dependent on blood flow and the affinity for the tissue. We'll be talking about that more in detail in the next slide. Distribution to other internal organs, muscle, fat, and skin is usually slower. One of the biggest factors that is important is protein binding, which we'll go into a little bit more detail later on. Drug distribution during pregnancy and lactation is important to consider. During pregnancy, most drugs cross the placenta, and during lactation, many drugs enter breast milk. In the previous slide, we talked about drug distribution and what factors that affect distribution. In this slide, we're going to talk about tissue affinity and blood flow. So after a drug is absorbed systemically from the site of administration, the drug molecules are distributed throughout the body by the systemic circulation. The accumulation of drug into tissue is dependent on both the blood flow and the affinity of the drug for the tissue. Blood flow is an important factor in determining how rapid and how much drug reaches the receptor site. Large organs that receive the most blood supply are the heart, liver, and kidneys. After distribution to other internal organs, muscle, fat, and skin is usually slower. Under normal conditions, limited blood flow reaches the muscles. However, during exercise, the increase in blood flow may change the fraction of drug reaching the muscle tissues. For example, diabetic patients receiving intramuscular injection of insulin may experience the effects of changing onset of drug action during exercise. Although the brain is well perfused with blood, many drugs with good aqueous solubility have high drug concentrations in the kidneys, liver, and lungs, but little or negligible drug concentration in the brain. This is because the brain and the spinal cord, capillaries, endothelial cells are surrounded by a layer of tightly joined glial cells that act as a lipid barrier. This added layer of glial cells around the capillary membranes acts effectively to slow the rate of drug diffusion into the brain by acting as a thicker lipid barrier. This lipid barrier, which slows or impedes the diffusion and penetration of water-soluble and polar drugs into the brain and spinal cord, is called the blood-brain barrier. This barrier is usually selective as it allows only drugs that are lipid-soluble or have a transport system to cross the blood-brain barrier and reach therapeutic concentrations in brain tissues or spinal cord. Drugs with high tissue affinity tend to accumulate or concentrate in tissues. For example, digoxin is highly bound to proteins in cardiac tissues and has a long elimination half-life for about 40 hours. Another example is tetracycline that forms an insoluble cleate with calcium. In growing teeth and bones, tetracycline form complexes with the calcium and remain in these tissues. Drugs that are highly lipid soluble tend to accumulate in lipid or adipose tissues. This process is reversible, but it will take a few days or longer for the drugs to be extracted out of the tissues even after the drug is depleted from the blood. Because the adipose tissue is poorly perfused with blood, drug accumulation is slow. However, once the drug is concentrated in the fatty tissues, drug removal from the fat may also be slow. For example, insecticide chlorinated hydrocarbon DDT is highly lipid soluble and remains in fat for years. In a few cases, the drug is irreversibly bound into a particular tissue. Many purine and pyrimidine drugs used in cancer therapy are incorporated into nucleic acids, causing destruction of the cell. One of the best factors that is important is protein binding. Drug molecules bound to plasma proteins such as albumin, which is abundant, are pharmacologically inactive because these complexes are too large to leave the bloodstream through the small openings in the capillary walls and reach the sites of action. It is only the free or unbound drugs in the bloodstream that are active and will leave through the small openings in the capillary walls to reach their sites of action, metabolized, and be excreted. While this process goes on, the plasma levels of the drug has decreased. Therefore, some of the drugs that are bound to albumin or plasma protein will be released to pass through the small openings in the walls of the capillaries to reach its target site of action. So in essence, the protein binding allows some of the drugs to be stored and then released when it is needed. So it's like a reservoir, it's like a depot. Some drugs are also stored in muscle, fat, or other body tissues and released gradually when the plasma levels of the drug falls. These storage mechanisms maintain lower, more consistent blood levels and reduce the risk of toxicity. Drugs that are highly bound to plasma proteins or stored extensively in other tissues have a long duration of action. Drug distribution during pregnancy and lactation is important to consider, as previously mentioned. During pregnancy, most drugs cross the placenta, and during lactation, many drugs enter breast milk. Drug protein binding is influenced by several important factors. Number one, the drug physiochemical properties and the total concentration of the drug in the body. The protein, quantity of proteins available for drug protein binding, and the quality of the protein synthesized. And number three, affinity between drug and protein. Number four, drug interactions, competition for the drug by other substances at a protein binding site, and alterations of the protein by a substance that modifies the affinity of the drug for the protein. And number five, the pathophysiologic condition of the patient. For example, drug protein binding may be reduced in uremic patients and in patients with hepatic disease. So the next slide is we're going to talk about a little bit more about these important factors of drug protein binding. The protein, quantity of protein available for drug protein binding, and the quality of protein synthesized. In certain genetic diseases, the quality of the protein that is synthesized in the plasma may be altered due to change in the amino acid sequence. Both chronic liver disease and renal disease, such as uremia, may cause an alteration in the quality of plasma protein synthesized. An alteration in the protein quality may be demonstrated by an alteration in the affinity of the drug for the protein. Affinity between drug and protein. The binding of drugs to proteins can affect the duration of action of the drug. A drug that is extensively but reversibly bound to protein may have a long duration of action due to a depot effect of the drug protein complex. We talked about this in a couple of slides back. For example, protein binding is most clinically significant for antimicrobial therapy, where a high degree of protein binding serves as a drug depot or reservoir, allowing for increased duration of action of the drug. Concentration remains above the bacterial minimum inhibitory concentration, adding to antimicrobial activity. So the portion of the the portion of the drug that is unbound are pharmacologically active, and they can cause an effect by going to the site of action. And they can become metabolized and then get excreted from the body. As the body is depleted of the pharmacologically active drug, the unbound portion, to maintain equilibrium, the bound portion of the drug that is bound to the protein or albumin is released from the depot or reservoir, and once again this drug becomes unbound from the protein. Okay, so then the unbound drug will, become pharmacologically active to cause an effect. Drug interactions, competition for drug by other substances at a protein binding site, and alteration of protein by a substance that modifies the affinity of the drug for protein. When a highly protein-bound drug is displaced from the binding site by a second drug, a sharp increase in the free drug concentration in the plasma of the first drug may occur, leading to toxicity. For example, an increase in free warfarin level that was responsible for an increase in bleeding when warfarin was co-administered with phenytoin, which is another highly protein-bound drug, and it competes for the same binding site as warfarin. So when warfarin is co-administered with phenytoin, which competes for the same binding site, then that will displace warfarin, and when the drug is unbound from the protein, there will be some consequences such as increased bleeding. As illustrated by the previous example of warfarin and phenytoin, the displacement is most important with drugs that are highly protein bound that have a narrow therapeutic index. The therapeutic index is a measure of a drug's safety. The therapeutic index is defined as the ratio of a drug's lethal dose 50 to its effective dose 50. The LD50, which is the lethal dose 50 or average lethal dose, is the dose that is lethal to 50% of the subjects treated. The effective dose, or the ED50, is defined as the dose that is required to produce a therapeutic response in 50% of the population. The ED50 is considered a standard dose and is often used as the initial dose of treatment. A large or high or wide therapeutic index indicates that a drug is relatively safe. Conversely, a small or low or narrow therapeutic index indicates that a drug is relatively unsafe. The therapeutic range is quantified or measured by the therapeutic index. There is a range of plasma drug levels falling between the minimum effective concentration and the toxic concentration, which is termed the therapeutic range. When plasma levels are within the therapeutic range, there is enough drug present to produce therapeutic responses, but not so much that toxicity results. The objective of drug dosing is to maintain plasma drug levels within the therapeutic range. The width of the therapeutic range is a major determinant of the ease with which a drug can be used safely. Drugs that have a narrow therapeutic range are difficult to administer safely. Conversely, once again, a drug that has a wide therapeutic range can be administered safely with relative ease. Drugs that have a narrow or low therapeutic range means that the drug that is effective is very close to the dose that causes adverse and toxic reactions. That means the lowest and highest acceptable drug levels are not that far apart. So for the example, we had warfarin. Warfarin can have an unpredictable effect in some patients, specifically in older adults greater than 65 years of age and in patients of Asian descent. Warfarin has a very narrow therapeutic range that produces the anticoagulant effects without also causing bleeding in the patient. Frequent blood tests are done to monitor bleeding risk while still providing the anticoagulant needed. To avoid variation in testing methods, a system called the International Normalized Ratio, or INR, is used to standardize PT or prothrombin time reporting. In a person who is not receiving anticoagulation therapy, the normal INR is 0.9 to 1.1. The typical INR goal for a patient who needs anticoagulation therapy is 2 to 3, except in cases of mechanical cardiac valve replacement, in which a higher INR is necessary to prevent clot formation. So got to keep the INR somewhere between 3 to 4.5. The INR goal may be different for specific disorders that require anticoagulation. Initially, the PT INR may be measured daily, but after the patient has been stabilized, tests are performed at about 1 to 4 weeks intervals. Depending on patient responses, another class of antibiotics that I would thinking about that comes to mind is aminoglycosides. And on this slide, I have noted some examples. There are many drugs that have narrow therapeutic index, but I've just listed a few on this slide. So aminoglycoside is one of them that have a narrow therapeutic range. So again, that means that the antibiotic level should be drawn just before the next scheduled dose to be given. The blood sample shows the lowest blood level of the antibiotic, called the trough level, rather than a blood level at a higher range called the peak level. The lowest blood level determines whether the dose needs to be adjusted to stay within the therapeutic range and not reach the toxic level or go below the effective dose. So you don't want the aminoglycosides level to be lower than the effective level. So you want to keep it in the target range. Aminoglycoside dose is calculated based on the patient's weight. The dose is adjusted according to creatinine clearance so that a therapeutic level is maintained without nephrotoxicity. BUN and glomerular filtration rates are also closely monitored. So this drug also can cause autotoxicity as well. So when you first place the patient on this medication, make sure you do your assessments and make sure they can hear well, and of course check their labs, the BUN, and the creatinine clearance, as well as the glomerular filtration rate. So the next drug that has a very narrow therapeutic range is Digoxin. So older adults are particularly at risk for Dig toxicity. Symptoms of toxicity may begin slowly and are often easy to overlook. So they'll have symptoms such as loss of appetite, nausea, vomiting. So these are like the common, side effects of Digoxin. But when they start complaining about visual changes such as blurriness that they are seeing, or they have some halo that they notice, like yellow little green spots, that's a late sign of Dig toxicity. So although the therapeutic serum digoxin level is 0.8 to 2 nanogram per ml, the ideal therapeutic range for both men and women in heart failure may be around 0.5 to 0.8 nanogram per ml. The serum blood level is drawn prior to the administration of the digoxin dose. The blood sample is drawn at least 6 hours after the previous dose, because distribution of digoxin to the tissues, and of course the digoxin has the affinity for the cardiac tissues, so you won't see the distribution until 6 hours later. Okay, so if the blood is drawn before 6 hours, the serum digoxin level may be elevated and not an accurate assessment of the therapeutic levels. And then another drug that is really important, that is used in bipolar disorder or acute mania, or even for long-term maintenance therapy for bipolar disorder, is lithium. So lithium has a very narrow therapeutic range, which means again that the dose that improves symptoms of the bipolar is close to the dose that can cause toxic effects. It is important to regularly monitor the lithium blood levels. The first blood level of lithium is usually measured about 3 days into therapy. So teaching points for patients who are starting on these drugs is to not get dehydrated and not to do a lot of activities that make them cause severe sweating, because these can result in low sodium, and when you have low sodium, it can increase the risk of lithium toxicity. So the lithium level should be between the ranges of 0.8 and 1.2 milliequivalent per liter initially, and then once they're on this drug and when you monitor, then preferably they want to keep the range a little bit closer to 1 milliequivalent. So 0.8 to 1 milliequivalent. So any level that is like beyond like 1.34 or 1.5 milliequivalent will run into toxic levels, and they're going to have symptoms. Lithium levels are typically measured every 2 months while the patient is taking the maintenance dose. The pathophysiologic condition of the patient. For example, drug protein binding may be reduced in uremic patients and in patients with hepatic disease. In patients with liver disease, there is a decrease in plasma albumin concentration due to decreased protein synthesis. In nephrotic syndrome, an accumulation of waste metabolites such as urea and uric acid, as well as an accumulation of drug metabolites, may alter protein bindings of drugs. Severe burns may cause an increased distribution of albumin into the extracellular fluid, resulting in a smaller plasma albumin concentration. It is important to examine why the albumin level is reduced in the patient. Reduced protein binding will increase free drug concentration. Metabolism is a way in which drugs are inactivated or biotransformed by the body. Sometimes metabolism is also written as biotransformation. Kidneys are the site of drug excretion, and only water-soluble substances are allowed to be excreted. Therefore, a function of metabolism is to convert fat-soluble drugs into water-soluble before it is excreted. Hepatic drug metabolism or clearance is a major mechanism for terminating drug action and eliminating drug molecules from the body. Genetic polymorphism influences metabolism by producing functionally different responses to drugs in ethnic groups or specific individuals. Now, polymorphism involves one of two or more variants of a particular DNA sequence and is less common variant in at least 1% of the people who are tested. Cytochrome P450 enzymes or CYP enzymes in the liver metabolize most drugs. Red blood cells, plasma, kidneys, lungs, and GI mucosa also contain drug metabolizing enzymes. The CYP system consists of several groups of enzymes, some of which metabolize endogenous substances and some of which metabolize drugs. The drug metabolizing groups are labeled CYP1, CYP2, and CYP3. Individual members of the groups usually metabolize specific drugs. More than one enzyme participates in the metabolism of some drugs. In terms of importance in drug metabolism, the CYP3A4 enzymes are thought to metabolize about 50% of drugs. CYP2D6 enzymes about 25%, CYP2C9 and CYP2C8 about 15%, and CYP1A2, CYP2C19, CYP2A6, and CYP2E1 in decreasing order for the remaining 10%. The cytochrome P enzymes are complex proteins in binding sites for drug molecules and endogenous substances as well. They catalyze the chemical reactions of oxidation, reduction, hydrolysis, and conjugation with endogenous substances such as glucuronic acid or sulfate. With chronic administration, some drugs stimulate liver cells to produce larger amounts of drug metabolizing enzymes. This enzyme induction accelerates drug metabolism because larger amounts of the enzymes and more binding sites allow larger amounts of drug to be metabolized during a given period. As a result, larger doses of the rapidly metabolized drug may be required to produce or maintain therapeutic effects. Rapid metabolism may also increase the production of toxic metabolites with some drugs, for example, acetaminophen. Drugs that induce enzyme production also may increase the rate of metabolism for endogenous steroidal hormones, for example, cortisol, estrogen, testosterone, and vitamin D. However, enzyme induction does not occur for 1 to 3 weeks after an inducing agent is started because new enzyme proteins must be synthesized. Metabolism also can be decreased or delayed in a process called enzyme inhibition, which most often occurs with concurrent administration of 2 or more drugs that compete for the same metabolizing enzymes. In this case, smaller doses of the slowly metabolized drug must be needed to avoid adverse effects and toxicity for drug accumulation. Enzyme induction occurs within hours or days of starting an inhibiting agent. Cimetidine, a gastric acid suppressor, inhibits several cytochrome P enzymes. Example, cytochrome P1A, CYP2C, CYP2D, CYP3A, and can greatly decrease drug metabolism. The rate of drug metabolism also is reduced in infants. Their hepatic enzyme system is immature. In people with impaired blood flow to the liver or severe hepatic or cardiovascular disease, and in patients who are malnourished or on low protein diets. Excretion refers to elimination of a drug from the body. Effective excretion requires adequate functioning of the circulatory system and of the organs of excretion, such as kidneys, bowels, lungs, and skin. Most drugs are excreted by the kidneys and eliminated unchanged or as metabolites in the urine. Some drugs or metabolites are excreted in bile and then eliminated in feces. Others are excreted in bile, reabsorbed from the small intestine, returned to the liver. This is called the enterohepatic recirculation, this process. So there were some drugs that are excreted in the bile, reabsorbed from the small intestine, returned to the liver, metabolized, and eventually excreted in urine. Some oral drugs are not absorbed and are excreted in the feces. The lung mainly removed volatile substances such as anesthetic gases. The skin has minimum minimal excretory function. Factors impairing excretion, especially severe renal disease, can lead to accumulation of numerous drugs and may cause severe adverse effects if dose is not reduced. Serum drug levels are laboratory measurements of the amount of drug in the blood at a particular time that reflects dosage, absorption, bioavailability, half-life, and the rates of metabolism and excretion. Usually, a minimum effective concentration, or MEC, must be present before a drug exerts its pharmacologic action on body cells. This is determined mostly by the drug dose and how well it is absorbed into the bloodstream. Therefore, to be beneficial, a drug must be present in concentrations at or greater than the MEC, or the minimum effective concentration. Toxic concentration is a level at which toxicity occurs. Toxic concentration may occur when a patient is given a large single dose of a drug. It may be from repeated small doses or slow metabolism that allows the drug to accumulate in the body. Between these low and high concentrations in the therapeutic range, which is the goal of drug therapy, that is enough to be beneficial without becoming toxic. The goal is to maintain drug serum levels in the therapeutic range. In clinical practice, measuring serum drug levels is useful in several circumstances. When drugs with a narrow margin of safety are given because their therapeutic doses are close to their toxic dose, such as the drugs that we discussed a few slides ago. We talked about Digoxin, Aminoglycosides, and Lithium, and warfarin is the other drug that has a very low or narrow therapeutic index. To document the serum drug levels associated with drug doses, therapeutic effects, or possible adverse effects, to monitor unexpected responses to a drug dose, such as a decreased therapeutic effects or increased adverse effects, and when a drug overdose is suspected. Serum half-life or elimination half-life is the time required for the serum concentration of a drug to decrease by 50% or one-half. It is determined primarily by the drug's rate of metabolism and excretion. A drug with a short half-life requires more frequent administration than one with a long half-life. Half-life can be used to describe drug accumulation. At one-half, the drug concentration will be 50% of the steady state value, or after two half-lives, 75% of the steady state value, and so forth. About 94 to 97% of a drug will be eliminated after 4 to 5 half-lives. When a drug is given at a stable dose, 4 or 5 half-lives are required to achieve steady-state concentrations and to develop equilibrium between tissue and serum concentrations. Because maximal therapeutic effects do not occur until equilibrium is established, some drugs are not fully effective for days or weeks. Like in some the psych drugs, it takes a long time to actually reach therapeutic levels. To maintain steady state conditions, the amount of drug given must equal the amount eliminated from the body. When a drug dose is changed, an additional 4 to 5 half-lives are required to re-establish equilibrium. When a drug is discontinued, it is eliminated gradually over several half-lives. This is an example taken from the Lenny's Advanced Pharmacology book for nurse practitioners and PAs. This example is of morphine used to explain the concept of half-life. Suppose the patient ingests 50 milligrams of morphine, and morphine has a half-life of about 3 hours. Therefore, after taking the morphine 3 hours later, the body stores of morphine dose will decrease by 50% or 1/2. 3 hours later, the dose left is 25 milligrams. Then another 3 hours goes by, the dose remaining will be 12.5 milligrams. Another 3 hours later, 50% of the drug is eliminated down to 6.25 milligrams. Then another 3 hours later, it is down to 3.125 milligrams. Then again, 3 hours later, it is down to 1.56 milligrams. This concludes the PowerPoint presentation of pharmacokinetics. Please stay tuned for part 3, which I will be presenting on the fundamentals of advanced pharmacology, and particularly will be discussing pharmacodynamics. Please subscribe to my YouTube channel, and there are other videos that you can watch that will help you with your educational journey in advanced pharmacology. Thank you very much.